presenting the neurocardiac therapy for heart failure study, which name is NECTAR. It's a randomized controlled trial of vagal stimulation for the treatment of systolic heart failure. Please, Professor Zannad.
I'm sorry, I'm standing before the paradigm, so...
Oh. No, because you both have to leave.
No, I know.
Yes,
yeah,
that's
fine. And thank you very much for this small shift in the program. I'm Dr. Zannad. I'm working in France, and I'm pleased to share with you the results of the NECTAR-HF trial on behalf of the steering committee, neurocardiac therapy for heart failure. And this is an ongoing trial which lasts 18 months, and we're reporting the primary event, the primary endpoint at 6-month results as an interim analysis. These are my disclosures. Autonomic nervous system balance is altered in heart failure, and to make the very long story very short, there is an increased sympathetic stimulation and a decrease in parasympathetic stimulation in general, and as a therapeutic target, the aim is to reduce sympathetic stimulation and to add vagal stimulation. And there are many devices which are currently pursued into this area. Various therapy aiming at resetting autonomic balance are under investigation. I am going to be reporting here the first randomized sham-controlled trial to evaluate whether right vagus nerve stimulation is safe and might attenuate cardiac remodeling in patients with systolic heart failure. Other competing trials are ongoing with spinal stimulation, with baroreceptor stimulation, and with renal denervation, and actually not only for hypertension, but more specifically so in heart failure. Patients were enrolled on the basis of low ejection fraction below 35%, symptomatic at class 2 and 3. They have both etiology, and they were fitted with the NECTAR-HF system device from Boston Scientific. And after 2-week recovery, they have a baseline evaluation and could be randomized to therapy on or therapy off, but all patients were implanted, so we had a sham control group. This is how the device looks like. This is the lead, which is wrapped around the vagal nerve, very close to the carotid artery, which is fitted with a stimulation device. These are the baseline characteristics, very standard heart failure population, class 2 and 3. You see that the majority of patients had ICDs, but they did not have CRT because we didn't want to compete with CRT in this specific area, but most of them have optimal therapy, background therapy. The primary endpoint was left ventricular end systolic diameter at 6 months. And the trial was neutral. You can see that there was no change in 6 months, not on the therapy group and not on the control group. So on the primary endpoint, the trial was neutral. We had a number of secondary endpoints, and peak VO2 and NT-proBNP were also neutral, no effect of therapy on versus control. Secondary endpoint explored functional capacity, New York Heart, and a number of questionnaires of quality of life, such as the Minnesota and the SF-36. And here we had significant changes with more improvement in New York Heart with therapy on than therapy on, and a better score with quality of life with therapy on compared to therapy off. And this was also consistent with some positive sign in the SF-36 physical dimension of quality of life. These results are difficult to interpret into the light of the primary neutral effect of primary event because these were subjective measures. And we did measure the blinding success of this, and actually there was partial unblinding because, device are very difficult to blind. The echocardiogram were totally blinded, but symptomatic subjective improvement may have partially be reflected some kind of placebo effect. So the conclusion is that although robust preclinical data showed the benefit of vagal nerve stimulation, NECTAR-HF, the first randomized sham-controlled trial, failed to demonstrate a successful clinical translation of VNS therapy to the primary endpoint of cardiac remodeling. There were statistically significant improvements seen in the quality of life measures. The clinical meaningfulness of this is still under investigation, and there was statistically improvement in this quality of life to be contrasted with the partial unblinding. There were no significant safety concerns through the 6 months. Primary safety will be assessed at 18 months. The trial is still ongoing, and additional clinical research may provide additional insight into the effectiveness of VNS for heart failure. And just a methodological conclusion is that this device trial needs definitely to be sham controlled, and this is the value of sham control, and we need to check for the blinding success. And in this trial, now published at the European Heart Journal Fast Track today or tomorrow, you will have also the result of the blinding process, which may help interpret the result of these subjective measures. Thank you very much.
Okay, thank you very much. As you may have realized, this is a really innovative approach for the treatment of patients with heart failure. Professor Zannad needs to leave early, so he will take the questions right now. So please identify yourself.
How long will be your trial in the end, and is it possible that you reach the primary endpoint at the end of the trial, or at this point are you sure that you won't get it?
Well, good question. I didn't mention that at 6 months, all patients were switched on. So the double-blind controlled period was only 6 months. The extension over 6 months, everybody is being stimulated, and this is going to be only safety. It's unlikely that we can have any efficacy result because patients are no longer compared on and off. They're all on therapy.
Hi, Melissa Walton-Shirley with Heart.org. Did you collect information such as brain natriuretic peptide levels to do subset analyses in the future so that you might understand why the quality of life improved, and maybe there's a disconnect between the left ventricular insystolic dimension and shortness of air?
Well, since there have been no significant change in BNP, we didn't really have this analysis of BNP versus functional capacity improvement, but it's unlikely that there would be any correlation between both. The bottom line is that any remodeling measure, whether it is echocardiography or neurohormones, were neutral, but there was patients said they felt better. And this is, of course, subjective. Whether this is related to therapy or to something else, potentially placebo effect, is open for discussion.
Okay. Are there any more questions?